Hello, I'm Julie Bishop, a sports medicine and shoulder surgeon at Ohio State University Wexner Medical Center, and I practice at the Jamison Crane Sports Medicine Institute. This video will be presenting a shoulder arthroscopy with a superior capsular reconstruction, otherwise called an SCR procedure. We perform this procedure in patients that we have determined do not have a repairable rotator cuff, but they have significant pain and shoulder dysfunction. We use a graft to substitute for the rotator cuff, and this video will take you through the procedure. This is how we position a shoulder for arthroscopy. The patient is in a seated position called the beach chair position, and the head is to the right under the blue drapes. We always mark out our anatomic landmarks and mark with a pen where we will make our incisions. We make an incision in the back of the shoulder, as this is how we get into the shoulder joint. We use a metal trocar to gain entry into the joint, and then we put the camera in through the trocar. Now the camera is inside the shoulder, and we take our first look at the joint. We see the humeral head to our right, and the socket or the glenoid is to our left. The bumper around the glenoid is the labrum, which is a bit frayed here, and then above is the biceps tendon inserting into the labrum. We look over to the right and we see the place where our top rotator cuff tendon, the supraspinatus, would normally be inserting, but there is just bare exposed bone. We bring the camera down the back of the shoulder and do find the intact rotator cuff tendons in the back of the shoulder, the teres minor, and part of the infraspinatus. This is our view of the front rotator cuff tendon, the subscapularis, which is intact as well. Now we use a spinal needle to help us localize the best spot for our cannula in the front of the shoulder, and we use this cannula to pass instruments in and out of the shoulder. This is our shaver, which we use to clean out any bursa tissue, inflammatory tissue, or remnants of the rotator cuff so that we can see well. We are now cutting the biceps attachment, as it is not healthy at all, and we will reattach this outside of the shoulder joint when the SCR procedure is complete. Now we use our Bovie or cautery device to help remove the soft tissue so that we can get to the bone on the top of the glenoid to perform the procedure. We use a shaver as well to remove the soft tissue, as it is essential to see the bone, as you will soon see as the video goes on. Now the bone is exposed, and we are trying to make it lightly bleed, as the graft needs to heal into the bleeding exposed bone. We next work on the area where the rotator cuff normally would insert. We call this the footprint of the greater tuberosity, but essentially this is where we will attach the graft in place of the prior rotator cuff supraspinatus tendon. Just like with our prior cannula, we use a needle to localize the best spot for this cannula, and then we use a knife to incise the skin. And then we insert the cannula, as you can see here. Again, we use our shaver to remove the soft tissue, and then eventually create a bleeding bone surface for the graft to heal into as well. We now bring in our burr, which is a bit more aggressive in creating the best surface for graft healing. Now we are looking from the side of the shoulder towards the glenoid, and we see again to the left the remaining teres minor and the infraspinatus tendons. We are now doing our final preparations with our shaver, and we are bringing this shaver in from the back of the shoulder and removing any soft tissue that could block our view. We are also making sure that the bone is completely prepared and we have the nice lightly bleeding surface. We are still looking straight on at the socket or the glenoid, and we feel that we are now ready to start placing our anchors. Again, we localize with a needle, and once we like the spot, we use a metal trocar to prepare the pathway for the anchor. We confirm that we like our angle, and then we bring in the trocar for the anchor that we will drill through and place the anchor through. We then insert the drill through the red-handled trocar, and we start to drill a pilot hole for the anchor in the bone. We then insert the anchor through the same guide. We use a hammer to mallet it down into the bone, and the anchor has thick tape-like suture attached to it, and we clip this out of the way in the front of the shoulder. We then repeat this same step coming from the back of the shoulder as we place 2 anchors well spaced out on the narrow amount of bone on the top of the glenoid. We repeat all of the same steps. We look at the glenoid surface to be sure that our angle of drilling will not drill into the face of the glenoid. And then we use our metal trocar. We then use our drilling trocar. We drill. And then we place our anchor. We constantly look at the joint surface to be sure that we do not perforate it. The glenoid is a very small bone and we must be very careful. We now place our anchors on the greater tuberosity or the humeral head. Again, we localize with a needle, and then we use a punch to create a pilot hole, and then we will place the anchor. This is the punch. For these anchors, we make a pilot hole and then mallet the anchor into that spot. And then we use a screw mechanism to seat the anchor. There are 2 kinds of suture attached to the anchor, a thick tape that we pass through the actual graft, and a thinner suture that we use for our measurements. We repeat all of these steps to place a second anchor as far from our first anchor as possible in order to create a wide surface for the graft to heal to. This is another cannula that we use as a working portal to assist with all aspects of securing the graft in place. Suture management to avoid tangling the sutures is imperative, and you can see that we have all 4 sets of sutures clipped and separated out nicely. We next placed our largest cannula. It is a special flexible cannula. It is quite wide, and this is the one that we will use to pass our graft. We must make sure that it is positioned properly, and then we will again use our shaver to clean out any bursa or tissue blocking our view, as visualization when we pass the graft is key. We now retrieve our smaller sutures called fiber wire so that we can measure the distance between all of the different anchors. We take the suture out our flexible cannula, and then we use an arthroscopic measuring device to measure the distance between the anchors. We first measure the distance between our 2 lateral anchors. These are the anchors on the humeral head. We next measure the distance between our 2 front anchors, the lateral anchor on the humeral head and the medial anchor on the glenoid. Our measuring device has numbers on the device itself, and we note these numbers, and we do have someone writing them down in the room for us so we can keep track. We then repeat this process for the anchors in the back, and we measure the humeral head anchor, again to the glenoid-sided anchor. Then, to measure the distance between the glenoid-sided anchors, we retrieve our back tapes from the back anchor, and we use these to measure the distance between the 2 anchors on the glenoid, and we continue to mark down these distances. Once we are done measuring, we retrieve all of our tape anchors, and we retrieve them separately and carefully so that we do not tangle, and then we clip all of them carefully outside of the body. As you can see, we have them all clipped in a systematic, untangled way for later graft passage. Now we'll go on to preparing the graft based on all the measurements that we just made. Our graft is an allograft, which means it is a donor. It is human dermal allograft, which is really quite thick dermis or skin. The graft comes pre-packaged, like you see, and we then must shape it to the dimensions of our patient and the measurements that we took. We must keep our orientation, and thus we mark on our towel M for medial, or the glenoid side, L for lateral, or the humeral side, P is posterior, or the back of the shoulder, and A is for anterior, or the front of the shoulder. Although this can be a very tedious process, it is very important to take our time and be sure our measurements are correct, as we need the graft to have the right tension in the shoulder in order to be effective. We don't want too much graft or it will be redundant and thus it will not be effective. We then cut the graft out with our knife as shown, and what we cut out will be exactly what we introduce into the shoulder. Now we are marking where we will pierce the graft with our sutures. First, we must mark the correct spots. Then, maintaining our orientation, we will use this punch to create a hole in the graft through which our sutures will be passed. Now we have brought the graft up to the shoulder and our flexible cannula, and we begin to pass our suture, being very careful about orientation and passing the correct suture through the correct spot on the graft. Our passing device has an attached loop, and that makes it much easier for us to pass the suture through the graft. We are very careful to pass our suture from the undersurface of the graft up through the superior surface, and we continually keep our sutures separated so that they do not tangle. We now tie one of the front anchor sutures on the glenoid to one of the back anchor sutures on the glenoid. We tie against this metal stick, and then we use the remaining limbs as a pulley system to eventually guide the graft into the joint and into the proper position. We then fold the graft on itself, and we use this grasping device to deliver our graft into the joint. Meanwhile, we are gently pulling on our two remaining medial sutures from the glenoid anchors, and we're using them to shuttle the graft into place in the joint. At first, it may seem as though there is suture tangled everywhere, but if we did a good job outside of the shoulder, keeping them separated properly, once we take the tension out of the two limbs that we are using as a shuttle, the graft really lays down quite nicely on the glenoid side. We then retrieve the remaining two sutures from the glenoid through another cannula, and we use an arthroscopic knot tying device to tie these sutures and thus firmly secure the graft to the glenoid side. We definitely are careful when tying and tie a very secure knot, as we do not want this knot to come undone. We then cut our suture and we move to the humeral or lateral side to begin our work there. And although there is yellow fat in the shoulder that is trying to block our view, you can see that the glenoid side of the graft is secured and fastened down very well. At this point, we still have 4 suture tapes through our flexible portal. We're going to take 2 each, one from the front and one from the back anchor, and we're going to take these to another anchor called a lateral row anchor. This second set of anchors will compress the graft nicely on the bone that we have prepared, and to do so, we must first take 2 of the suture tapes out a side cannula so that they are not in our way. Once we find this spot, we mallet or hammer down the anchor until you can see the actual anchor itself. Then we hit the inserter device again and we fully seat the anchor. Once the anchor is all the way down, we can then cut our suture. We then retrieve our remaining 2 tapes and we repeat that entire process all over again. We load the anchor outside of the body, and then we place this anchor through our flexible portal, and with the metal tip, we again find the best angle on the bone. We then mallet it down in a similar fashion to the other lateral row anchor, and again, once our anchor is completely down, we will cut the suture. We next will make another accessory cannula so that we can tie the back of the graft to the remaining rotator cuff in the back of the shoulder. We will view through this portal. We place our camera through what we call our posterior lateral portal, and then we will work through the remaining portals to perform this part of the case. Once again, we are using the shaver to clean out the soft tissue that is obscuring our view and making it hard to see. It can be easy to mistake bursa for the remaining rotator cuff, and we really don't want to do that. Thus, we really need to see the rotator cuff well, and you can see that just to the right of the shaver is the rotator cuff, and once we've cleaned out this bursa, it is much more visible and easy to discern. We now pierce the posterior rotator cuff with this piercing device. And once we pierce the cuff, we retrieve the loop. It is called a nitinol wire. And we use this loop to shuttle a suture back through the rotator cuff. We then put some tension on the graft in order to ease the ability to pierce the graft in a similar location so that we can shuttle that same suture up through the graft. We then retrieve both of these sutures so that we can tie them similar to before with a special arthroscopic knot tying device. As you can see, when tying, this brings the back of the graft over to the remaining rotator cuff quite nicely. You also see nice red blood vessels in the remaining rotator cuff, and they will certainly aid in the rotator cuff healing to this graft. You can see that there is still a gap between the posterior rotator cuff and the back of the graft, and thus we do repeat that same step 2 more times. We pierce the rotator cuff, retrieve the wire, we shuttle the suture, and then we pierce the graft, retrieve the wire, we shuttle the suture, and then we tie them. We repeat this 1 more time, and once again, we cut the tails of the suture, and this brings the graft much closer to the posterior rotator cuff so that they can heal together. We have repeated the process a 3rd time, and here we are tying that final knot. This is now a very nice view of the side-to-side repair of the back of the graft to the posterior rotator cuff. This shows great compression of the graft laterally or against the prepared humeral bone. And here we are oriented looking at the medial attachment to the glenoid, which you can see is secured well, and you can also see the side-to-side repair to the left. Here you can see that we have secured the front of the graft to the front tissue in the shoulder called the rotator interval. This gives some security in the front, and we did this in a very similar fashion to what we did in the back of the shoulder. And then we'll take one final view. The final shot also shows that we've removed bone spurs that are above the graft, and thus there is a nice flat surface above the graft, and we're very pleased with our results and our security of the graft.